All right, hello and welcome to Alterations of the Pulmonary System. We're going to be going over asthma, bronchitis, and emphysema. I know that says COPD, but chronic bronchitis and emphysema actually fall under COPD. So let's jump into a little refresher of normal pulmonary anatomy. It shouldn't be too far back in your memory. So we have the lungs, which are comprised of several different things: bronchi, bronchioles, and alveoli. And you can see there the bronchi are kind of those bigger tubes right there. The bronchioles are smaller. And then if you could zoom in really close, you could see the alveoli, which are the functional unit of the lungs. And you can see that you have the alveolar sac there, the alveolar duct. So a lot of important things happen in the alveoli. A little refresher on pulmonary and bronchial circulation. So I searched high and low for a good illustration of this, and it was super hard to find. So once again, I want to say that kind of like the heart has to pump blood and supply blood to the rest of the body, it also needs a blood supply itself. The lungs are no different than that. So we have the pulmonary circulation, which supplies the alveoli. We have the bronchial circulation, which supplies lung tissue in the bronchi. Now, the pulmonary circulation, that is a low pressure system. It is highly elastic, very thin vessel walls, and it is not as muscular as the systemic circuit. We have pulmonary arteries, and those arteries, we also have veins, and they travel with bronchi, and they extend into the visceral pleura. So that's the pulmonary circulation. The pulmonary veins drain into the left atrium, and they even contain some cardiac myocytes. Then we have the bronchial circulation, because the bronchi, like I said, they require their own blood supply. That comes out of the systemic circulation. We have the right bronchial artery, which comes from an intercostal artery. And then on the left, there are two arteries with separate origins that come out of the aorta. So a third of the venous blood from the bronchi goes back into systemic circulation, and the rest forms what's called a physiologic shunt. So that is where oxygenated and deoxygenated blood mix together. Then we have the diaphragm and accessory muscles. And I'm so sorry for the way that the pictures on this presentation keep going over the letters. It looks much better if you download it on the computer. Um, if these pictures look familiar, that's because I took them straight out of my last presentation. I just think they're that good. So the diaphragm is a dome-shaped muscle, and it separates the thoracic cavity with our heart and lungs from the abdominal cavity. And remember, at rest, it curves up. When we inhale, the diaphragm moves down because it has to make more room for the lungs to expand. And when that happens, the pressure in the lungs goes below atmospheric pressure, and air flows right into the lungs. Now, when we exhale, which is called exhalation, the diaphragm relaxes, moves back up, and that pushes that air out. So then we have accessory muscles. You can see them labeled right there. And someone's accessory muscles, unless they're exercising hard, they should not be using them to breathe. So very frequently when I chart on patients, even if I don't listen to their breath sounds. If I want to comment on their work of breathing, which we discussed that term in my last lecture, I will say speaks in full sentences without use of accessory muscles, just to convey that someone is breathing evenly. That's kind of like some objective charting. And you have a factual way to state that when you didn't even have to put a stethoscope to somebody's chest. So, some gas exchange and ventilation basics. Remember, ventilation is the movement of air in and out of lungs. Once again, ventilation is what we would normally call like the respiratory rate. So that is ventilation. That is mechanical movement. That is something that we can see with our eyes, somebody ventilating. Perfusion is the blood flow through the pulmonary circulation. Now, diffusion is something that we cannot see. Well, perfusion and diffusion are things that we can't see just with our eyes alone. Um, but diffusion is something that happens deep in our lungs, and that is the movement of oxygen and carbon dioxide across the alveolar capillary membrane. So there's that little picture there in the right bottom corner of how that happens. The O2 comes into the alveoli, and I'm sorry, the CO2 comes into the alveoli. It's exchanged for oxygen, which flows back out to the capillaries. Remember, we have those airway defense mechanisms. We have mucus that traps particles. I know mucus is gross, but it does serve a good purpose for that reason. We have cilia that sweep debris, so they, sweep things that shouldn't be in there out. And then we have immune cells that fight infection. So remember those alveolar macrophages. So the first thing we're going to talk about is asthma. Now, as we go through these exemplars in this lecture, I think it's really important. I want you to think about where in the lungs, where in the respiratory system these things are happening. So, a little bit about asthma. I would bet all the money in my bank account that I have at least some of you who are listening who have asthma or experienced asthma as a child. It is a chronic inflammatory airway disorder. It is often triggered by allergens, irritants, exercise, and it primarily affects the bronchi. It can affect the bronchial tube, but it affects the bronchi. So people really think of asthma as a pediatric disease. I mean, adults, they think of them as having it, but a lot of people are like, oh, I outgrew that. Not necessarily true. Things are a lot more obvious in airways with kids because their airways are so small. So, if you had asthma as a kid, you still have it as an adult. It's just dormant. I'll come back to that in a minute. Here's a little bit deeper on the pathophysiology of asthma. So, what this is we say it's a bronchial hyperresponsiveness. Hyperresponsiveness. So, the bronchi are just a little too sensitive. They're a little too quick to lock down, tighten up with any kind of irritant. And what happens is that people with asthma have airway inflammation, and we say an exaggerated response to triggers. Now, these triggers can be allergens. So, here in New Mexico, probably don't have to tell you, but cottonwood, juniper, ragweed. I think ragweed's kind of all over the place. Um, pet dander, all kinds of stuff. Roaches, gross, I know. Um, all those things are major allergens. Can be an infection that kicks this off, like a respiratory infection. Could be cold air. could be exercise, definitely could be smoke. So one of these things triggers an inflammatory response in the airway. And when that is triggered, the airway lining, so the epithelial lining releases inflammatory mediators. So those are histamine, leukotrienes, and prostaglandins. And you probably remember a little bit about histamine from, I don't know, our like endocrine lecture, but all those things are going to cause swelling, which we now call edema, vasodilation. So those vessels are going to get thrown wide open, the blood vessels, not the bronchi, and mucus production. And then we have what's called bronchoconstriction. So we have these bronchi that are tightening up, and then making matters worse, we have mucus that is being overproduced that can block the small airways. And that leads to air trapping and hyperinflation. So, what ultimately happens is that makes it harder to exhale than it is to inhale. So, you have all this air trapped inside, and it's increasing the work of breathing. So, that airflow is trapped. There's not proper oxygen and carbon dioxide being exchanged. So this can become very dangerous very quickly. So here's a simplified step by step. Get exposed to trigger, you have mast cell activation, airway swelling and mucus production. Bronchoconstriction leads to airway limitation. And then there's also an immune element, an immune response in asthma. The IgE binds to allergens and leads to mast cell degranulation. This releases histamine, leukotrienes, and prostaglandins, just like I said before, and eosinophilic inflammation. And our eosinophils, as you might remember from biology, are always linked to allergies. So there is also a late asthmatic response, and it begins 4 to 8 hours after the early response. And this is when um, those inflammatory mediators have been released and they incite bronchospasm, edema, and mucus secretion, which obstructs airflow. And then airway remodeling can occur, and that's irreversible. So that completely changes that epithelial lining and the architecture, basically, of the bronchial tube. So here's a kind of a blurry picture with at the bottom that late response to asthma. So once again, here are some triggers of asthma. I think I went over a lot of them. Dust mites is one I didn't say, mold, fragrances. So sometimes I feel like it's very hard to escape fragrances. It's good to be mindful of that with our patients because a lot of fragrances can be a trigger. Um, Cleaning chemicals, those can definitely be one, especially things with bleach in it, and pets. I'm sure a lot of us have experienced that. There's also a familial link to this. If your parents had asthma, like you're more likely to have asthma. And then there's something called the hygiene hypothesis. And this is a very interesting hypothesis. It is just a hypothesis. So it's not necessarily proven, but um, there are people out there who say, wow, like it seems like people just have way more allergies than they used to. Um, and one idea behind this is that people say our world has become a little too clean, meaning that if people are not exposed to a range of microbes like bacteria, viruses, and parasites when they're young, their immune system doesn't get trained to fight them, and it can manifest in things like food allergies, asthma, eczema. So once again, this has not been 100% proven. This is just a hypothesis, but the textbook does mention it, and I think it's kind of some interesting food for thought. I can kind of think of people in instances that would prove this true. I can kind of think of some people that would prove this false. So here's another really key aspect of asthma is that it is reversible, um, except if there's remodeling, but it is reversible airflow obstruction. Um, so you have these narrowed airways, and somebody has these narrowed airways. What do we do? Well, we give them something called bronchodilators. That is a picture of albuterol. Maybe some of you have an albuterol inhaler. That is known as a rescue inhaler. It's not going to do someone any good if they're not having an asthma attack, which when I say asthma attack, I mean, that whole thing where um, their airflow is obstructed because they got triggered by an irritant. Um, so bronchodilators like albuterol are to reverse that muscle constriction as it's happening. Um, how is asthma diagnosed, or actually clinical manifestations of asthma? So we've all probably heard wheezing, at least on a video. And if you haven't, I encourage you to look that up. Wheezing happens in the bronchi, and you hear it more on exhalation, which exhalation also means expiration. So you will hear that wheeze as someone breathes out. Now, if it's not super severe, you might not be able to hear wheezing without a stethoscope, but you would kind of hear it in the upper lung fields. Um, when you put your stethoscope on. And there's another little infographic, and it kind of shows in the right bottom hand what it looks like normal bronchi versus asthma versus during an asthma attack. So you can see that even after that asthma attack, that airway does look a little different. Um, so I don't know if any of you all have seen someone have an asthma attack. It can be quite startling when it is really severe, because if it goes on long enough, somebody will progress to something we call status asthmaticus. And um, that becomes very dangerous, because status asthmaticus is when we have that bronchial constriction, and it's not reversible with a bronchodilator. So, how is asthma diagnosed? Well, a peak flow test will tell us a lot. And this is something that ideally, um, your doctor or a doctor or a medical provider, they should be checking on somebody with asthma every time they go for a checkup, because you can tell a lot about somebody's asthma management from their peak flow meter. So what a peak flow meter is somebody will take a deep breath, and then you have them blow out as hard and as fast as they can. And as they exhale forcefully, it moves this little gauge up a meter. And there's a calculation. You can look it up if you're curious. It's based on weight, height, ethnicity, and sex. And so it corresponds to what your peak flow should be. Um, and that will tell you a lot about somebody's control of their asthma. So sometimes people actually feel pretty good, but they could be in the yellow zone, and that could require different medication management. So what peak flow is measuring, I want to be really clear about this, is it's measuring how much somebody can exhale when they try to exhale as hard and as fast as they can. So if their asthma is not well managed, then this is going to be a lower number. They're not going to be able to exhale as forcefully. So that's one element of diagnosis and ongoing monitoring. We also get a detailed history. So, when did their respiratory problems start? Was it correlated with any kind of irritant or exercise? We do a physical assessment and listen to the lungs. Now, if they're not having an asthma attack, we won't hear wheezing. And then allergy testing is helpful, more not so much to diagnose the asthma itself, um, but to manage the asthma. Like if we find that it's linked to a certain allergen, then maybe we can give medication for that, and help control asthma better. So once again, complications of poorly controlled asthma. You can have airway remodeling, and that is a permanent change where basically somebody has such poorly controlled asthma that their bronchi have like completely changed. The way they're built, like the epithelial lining changes, it's tightened. And then once again, status asthmaticus, this is extremely life-threatening. It is when the asthma exacerbation is so severe that a bronchodilator like albuterol doesn't help. So, really important that asthma is managed, that people are having their peak flow, they're monitoring their peak flow, even though you're going to find that that doesn't happen a lot. I sadly meet a lot of people with asthma that, don't even know what that is. You could be one of them. So as nurses, we need to take it upon ourselves to educate. So it's really important with asthma that those irritants be avoided. Definitely should not be smoking anything. Um, you know, Cigarettes, marijuana, whatever. Shouldn't be doing it. And once again, I want to go back to that point. A lot of people think that they outgrow um, their childhood asthma and it can go dormant. But as an adult, that epithelial lining is always a little bit different. And so it only takes exposure to an irritant or a bad upper respiratory infection to produce that airway hyper responsiveness all over again. And there are some people that develop asthma as adults who didn't have it as kids. So you could have a particularly bad upper respiratory infection or just respiratory infection in general, for example, or develop an allergy to a new irritant or just an irritant of any kind for that matter, and experience that airway hyper responsiveness. So um, that is asthma. So here is a bit about bronchitis. Now, bronchitis is an inflammation of the bronchial tube. This involves mucus overproduction and cough. So, first of all, let's talk a bit about acute versus chronic. So, a lot of us have probably had acute bronchitis. So, this is often viral and it's self-limited, meaning, yeah, we're not going to feel great while it's going on, but if we just kind of lay low and take medications for comfort. Maybe we'll need a bronchodilator, but it will ultimately run its course. And then there's chronic, which is actually under the COPD umbrella. And this requires a productive cough for 3 or more months out of the year for 2 years. So we'll dive more into chronic in a minute. The pathophysiology of acute bronchitis. So, a viral infection causes airway inflammation, and this causes increased mucus production and cough. So, similar to asthma in the area it affects, but when you think about bronchitis, I want you to think about just this pretty large amount of mucus. Um, Very, very severe mucus response. So there's a little cross section of what the bronchi look like normally and with bronchitis. So we do have airflow limitation with bronchitis because of partially obstructed airways, and this increases resistance. But um, with the bronchitis, we more have the partially obstructive airways because of mucus production, not because of this like muscular constriction, not the bronchoconstriction. But we will have coughing. We still could have some wheezing with bronchitis because wheezing is just the sound of air moving through narrowed passages. I'll, very, very productive cough. The cough is protective to clear that mucus out. And then we could have dyspnea and chest tightness. So those things will increase the work of breathing. But once again, acute bronchitis, it is self-limited. It's usually due to a viral infection. So let's move into COPD. So, COPD is a group of diseases that cause airflow obstruction and breathing problems. So, under the COPD umbrella, we have emphysema and we have chronic bronchitis. And here's our little nicknames that'll make a little more sense later. Emphysema is something that affects the alveoli, and chronic bronchitis, um, it affects the bronchi. So let's move in to, here's another little illustration, just a little side by side. Let's move into chronic bronchitis. So chronic bronchitis, it's like acute bronchitis in that there's mucus overproduction, but this is long term. And this is very, 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 very much tied to cigarette smoking. And so this long term irritation, typically from cigarette smoke, is going to affect the bronchial epithelium. So there is injury and irritation of the bronchial epithelium from that chronic exposure. So this leads to persistent inflammation, um, which those irritants trigger chronic low-grade inflammation, and then we have neutrophils, macrophages, white blood cells just rush into those airway walls. They release what's called proteases, and proteases are enzymes that break down connective tissue. So that causes tissue damage and remodeling. So those irritants just, I mean, imagine if you have seen anyone who smokes cigarettes, typically people are smoking, a pack a day, which is like 20 cigarettes. Or, they could be vaping. And I know that there's some stuff out there. It's kind of controversial. Is vaping better than smoking? I'm not really going to comment on that because I don't know. I kind of have an opinion that I won't express, but suffice it to say, um, any of those things that we're inhaling that aren't just straight up air or oxygen, it's going to be irritating to our lung tissue. So that persistent inflammation triggers this, uh, all of these neutrophils, macrophages, and white cells to rush in, and then the proteases are released, which contribute to that tissue damage and remodeling. So we have that aspect. And then because mucus wants to help us, it wants to protect us, it wants to get rid of irritants. Well, it's being exposed to irritants all the time. So those goblet cells are going to develop hyperplasia. That means there's going to be more of them. And then we have our submucosal glands hypertrophy, so they get bigger. And then we're just having more and more and more mucus that's just filling up the bronchi. And if you meet somebody with chronic bronchitis, they're your patient who, gosh, I don't know if you've encountered this yet. You will one day. It's like the grossest thing to me. Um, they're that patient that they're just constantly like coughing, 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 and they have about 25 styrofoam cups around their room, and they're like, get me some water, and every single one you pick up is full of, nasty greenish gray yellow mucus. Ugh, yuck. So gross. But yeah, I mean, these people with chronic bronchitis, that mucus is just an overdrive. Then they have something called ciliary dysfunction. So remember, those cilia, they're those little sweepers that line the bronchi, and they're our friends. But when somebody smokes, it kills those cilia. It damages them, it paralyzes them, so they can't properly clear mucus. And what happens is that mucus can just sit there, and it's like a perfect little petri dish in our body for bacteria to flood in there and create recurrent infections. So, I don't want to get too much beyond the scope of this lecture, but you can imagine that this little petri dish, perpetual petri dish of mucus, is a perfect environment to create bacterial infections. That's why people with chronic bronchitis, they're very vulnerable to getting pneumonia. Um, so interesting fact, uh, cigarette smoking kills cilia. So I used to be a cigarette smoker. I smoked quite a lot. And one thing that would happen to me every time I would quit smoking for a while is I would feel good. And then about 3, 4, 5 days in, without cigarettes, I would just develop just the gnarliest cough. I would feel horrible. And I would just start coughing like crazy. And I would actually feel worse in my body, like feel a lot sicker, like not smoking during those days, than I would when I was smoking cigarettes. So I read up on it a little bit, and I found out, when you stop smoking, your cilia will actually start to function again. And I don't know if that's true for people who smoked for like 40 or 50 years. This time I had just smoked for like 5 to 10 years. So sometimes like people feel worse before they feel better because that cilia actually starts to function and they start coughing things up. So moving on, we have with chronic bronchitis, airway remodeling and narrowing. So this repeated cycle of injury and repair leads to what's called fibrosis, so stiffness and thickened bronchial walls. So the smooth muscle hypertrophies and the airway gets narrow. And this creates an obstruction that is not fully reversible. That combined with the mucus clogged airways creates that resistance to airflow, and air gets trapped in there. So, how this ends up manifesting is in poor ventilation of mucus filled areas. So, that leads to what's called chronic hypoxemia. And this is called a ventilation perfusion mismatch. So remember, ventilation is that the mechanical aspect of breathing. So it's that respiratory rate. Perfusion is blood flow through the lungs. So a ventilation perfusion mismatch is when, somebody's breathing, like you see them inhaling and exhaling, but what happens afterwards, that gas isn't moving through the way that it needs to. So somebody with chronic bronchitis has chronic hypoxemia, so not enough oxygen in their blood. And then long-term hypoxemia can even cause pulmonary vasoconstriction, which can increase the pressure in the pulmonary arteries, which causes something called pulmonary hypertension, which can lead to right-sided heart failure, which we talked a little bit about in our last unit. So for now, you can, okay, this wasn't the illustration I thought it was. Yeah, so actually don't call people this, but in the scope of like the classroom, call somebody with chronic bronchitis a blue bloater. Why? Because they have like this bluish tinge to their skin. I mean, not necessarily really dramatic, but if you look at their nail beds or you kind of look around their mouth, now it all is going to depend on somebody's amount of melanin in their skin. If somebody has a lot of melanin in their skin, they have a darker skin tone, it's more subtle. Um, but somebody can have kind of a bluish purple tinge from this chronic hypoxemia. And then they're bloated because of this uh this cor pulmonale, this right-sided heart failure, and the pressure that puts on the systemic circulation. They have constant rhonchi and wheezing. Rhonchi is another name for that kind of like wet, junky, congested lung sound. Um, so yeah, you can read some of those other pointers, but remember, chronic bronchitis, we think of blue bloaters. So how is this diagnosed? Well, detailed history and physical. If somebody has a pretty long smoking history and they're constantly going to see the doctor for respiratory infections, getting pneumonia, they're just coughing up mucus all the time, they probably have chronic bronchitis. There are pulmonary function tests, and that is something that a respiratory therapist usually conducts. And there's a lot of measurements of lung volume, of expiratory volume, of like tidal volume, like a lot of different measurements. We won't really get into that in this class too much. And then they can also do a chest x-ray, and that is more to exclude other pathologies. A lot of this is really just based on history and physical findings. Once again, if somebody does not get this under control, it will progress to right-sided heart failure. All right, so moving on to emphysema. So sometimes people, and when I say people, I am one of these people. I catch myself using the term COPD and emphysema interchangeably. Emphysema is chronic airway inflammation, um, and it affects the alveoli. And that alveolar destruction leads to a loss of elastic recoil. So those little like alveoli are kind of like little sacs. And remember, I talked in last week about surfactant. They ideally have like a little bit of elasticity to them, but when they get destroyed, they kind of lose that elastic recoil, so you can't have good gas exchange across them. Um, Something called a protease antiprotease imbalance is present. And remember, protease are it's an enzyme that breaks down elastin and connective tissue. and the anti-protease work against them, but in emphysema, there's way more protease than anti-protease. And so this leads to alveolar septa being destroyed, and we don't have as much surface area for gas exchange. So, um, let's see. There is something called alpha 1 antitrypsin, and alpha 1 antitrypsin is a protective protein that is mainly made in the liver and it's released in the blood. And it really protects the lungs from damage during inflammation. So sometimes people have emphysema not because they smoked a long time, but because they have a genetic lack of this alpha 1 antitrypsin. So this could be there are people out there that have emphysema that have never touched a cigarette in their life, have never lived around a smoker. And it's really, really sad because there's a lot of stigma connected to emphysema and lung cancer in general because number one, people think that um let's see. I think sometimes people think that if they can find, the bad thing that someone did to quote unquote bring the disease onto the patient or bring it on themselves, then it's okay to judge them. When really, like, we're there as nurses to care for patients, not to judge what brought them there. But people generally feel okay when somebody has lung cancer or pretty severe emphysema, just kind of shrugging their shoulders and being like, well, they smoked a lot. Like, what did they think would happen? And that's never okay. But it's especially sad when somebody has lung cancer or they have emphysema. And it's really due to like nothing. Like it's just a genetic abnormality. I feel like I'm not phrasing that well, but I think you get where I'm headed. Um, Okay, gas exchange impairment in COPD, meaning emphysema. We have that ventilation perfusion mismatch due to air trapping. And then we have CO2 retention. So that carbon dioxide, because the alveoli are damaged, it can't really get out the way that it should. It's not exchanging properly. So it gets trapped in somebody's body. And the body likes to be at a pH level of 7.35 to 7.45. Um, when we have too much CO2 in the body, it's going to make our body acidotic. And when that acidosis comes from the respiratory system, we call that respiratory acidosis. So, in a couple levels, you're going to get into ABG, arterial blood gas interpretation. So that's fun. You'll get to figure out how to know based on somebody's results, are they acidotic or alkalotic? Where is it coming from? But that's all you really need to know for right now. So people with emphysema, it's kind of interesting. Their drive to breathe becomes different than the normal drive to breathe for somebody who doesn't have emphysema. They kind of become, mm, their bodies, kind of has to start tuning out that amount of carbon dioxide because it's just there all the time. So normally, carbon dioxide levels rising is what prompts us to breathe. We don't really have, if somebody has emphysema, they kind of lose that. So that's why we need to be really careful when somebody has emphysema. We can't turn their supplemental oxygen way up. They actually need to be slightly on the edge of hypoxemia or hypoxia, slightly. When I say slightly, I mean, it's acceptable for them to have O2 sats between 89 to like 92% is often how you will see an order written for somebody with emphysema because they need that to drive them to breathe. So if we give somebody with emphysema, if we were to like crank their oxygen up to 6 liters per minute versus 2 and target O2 sets of 99%, it could actually kill them because they would lose their drive to breathe. So, kind of an interesting phenomenon. It's fascinating how the body will adapt to dysfunction. So COPD exacerbations, this is when, somebody's already not breathing great with one of these chronic conditions, but, say they get a respiratory infection or they're exposed to pollutants, they will have worsening dyspnea. So dyspnea means difficulty breathing, sputum changes, this often looks like, um, they might need to be hospitalized, they might need more supplemental oxygen. Um, and yeah, the goal for somebody with COPD is to prevent exacerbation. So once somebody has COPD, this is not really reversible. It has very limited reversibility, if at all. But what we can do is prevent exacerbations. So back to our blue bloaters and pink puffers. Now, our patients with emphysema are the pink puffers, and they do not have that blue tinge because they typically hyperventilate. So that keeps enough oxygen or nearly enough oxygen, enough in their system that they're not cyanotic, so they're not turning blue. Having to work so hard to breathe actually causes weight loss. So these people are usually like very, very, very thin, sometimes like skin and bones even. They have this chronic dyspnea, especially as this disease progresses. The dyspnea gets more and more pronounced, even just talking can wear them out. They're burning a lot of calories breathing. They have what's called a barrel chest, because they uh, have hyperinflation of their lungs. So their lungs are trying to make up for the fact that there's alveolar destruction. So there's hyperinflation. You will see them do something called pursed-lipped breathing, and this is actually something that, we will coach them to do a little bit where they'll kind of tighten their mouth into a tiny O, and that kind of prolongs that expiration and it keeps the airways open longer. Um, yeah. So they will often have diminished breath sounds. Somebody with emphysema does not have a lot of sputum necessarily. Now, I'm speaking about this as a pretty black and white issue. The truth of the matter is, when you get out into clinical practice and you start seeing people with these problems, the reality is people can kind of have a mix of the two. But for the purposes of this class and for texting purposes, I'm going to teach you about it as if these are, two distinct problems. So, um, remember, chronic bronchitis is mucus hypersecretion and airway obstruction, um, and it affects the bronchi. Emphysema is alveolar wall destruction and hyperinflation. So, diagnostic tools, spirometry, um, which is part of a pulmonary function test. ABGs will show hypoxemia, so that's a lack of oxygen in the blood. Hypercapnia means too much carbon dioxide. And if we did an X-ray, it would show hyperinflated lungs. So their lungs would just look huge compared to normal lungs. One point I do want to make, I remembered about asthma. So let's talk a little bit about lung sounds. So I said with bronchitis and with emphysema, you're generally going to have some rhonchi, some crackles. With bronchitis, you could have wheezing. With asthma, you have wheezing, but what is even more dangerous, how you know that things are really going bad with your patient with asthma is if you put your stethoscope to their chest and you hear like nothing. So that means that you have airways that are like almost completely constricted and you have to act very fast to keep that person alive. So, sorry, I forgot to say that when we were talking about asthma. So the key difference is asthma is reversible inflammation, affects the bronchi. Chronic bronchitis is mucus and chronic cough, happens in the bronchial tube. Emphysema is alveolar destruction. Um, so treatment for emphysema, I want to go back to that for a minute. That looks like, so for one, I want to highlight it's not reversible. For our patients who smoke cigarettes, and that's a reason for their emphysema, the good news is that if they stop, then they can prevent further progression, further disease progression. But somebody with emphysema will likely need supplemental oxygen. They need to be on inhaled steroids twice a day. They will need to have a rescue inhaler handy. They will like might need oral steroids if they start to have like an exacerbation. So these are patients who um you'll see doctors and providers are very quick to give them antibiotics for respiratory infections because things can become really scary and really severe for them very quickly. Really, really important that these patients get their flu and pneumonia vaccines, and we want to help them with smoking cessation. Um, oh, positioning. So people always breathe better, number one, sitting upright. You will see people, especially with emphysema, do that kind of tripod breathing, and you can often help people in a position where they're kind of leaning forward on their elbows. Maybe like if they are in the hospital, they have a bedside table propped up and kind of leaning over it. Um, so those are some nursing interventions and treatments. That is an overview of asthma and COPD, including bronchitis and emphysema. I hope that helped you. Happy studying, and I will talk to you soon.